Hello everyone, and welcome to week number 2 here at Rasmussen and with your clinical course. This week we will be focusing on 2 chapters, and those 2 chapters are going to be chapter 26, pages 586 to 593, and chapter 39, pages 886 to 895. So let's go ahead and talk about each one of those for this week. So chapter 26 is going to be focusing on the eye, and that's what this whole week's model is going to be about, the eye. I want to start kind of discussing the eye itself, the structure of the eye, and the diseases associated with the eye. So your eye is a spherical, fluid-filled organ composed of structures that help to facilitate vision, or sight. Those structures are your cornea, pupil, lenses, and retina. Now, your nervous system will play a very large role in the sense of your vision. The nerves of your eyes are used to help control the amount of light that enter the eye through your pupil. The nerves of your eye also help to focus light on the retina by using your lens. And they also transmit the resulting images from your retina to your brain so you can know what you're seeing. So let's go ahead and discuss the structure of the eyeball. Now, the eyeball itself is housed in a cavity within the skull of your brain, or within the skull of your body, called your orbit. The eyeball is divided into 2 cavities, the front cavity and the back cavity. And the surface of your eye actually has 3 different layers. The outer layer, which is also called your sclera, you have your middle layer. This layer will include the chondroid, the iris, lens, and the ciliary body. And then you have your inner layer, which is also called your retina. Now, beyond that, there are external structures that are associated with your eye, not just the internal ones that I've just named. Some of your outside structures are used to help protect and support your eye and keep you from getting harmed. You have your eyelid as an outer structure, the conjunctiva as an outer structure, the lemmacril apparatus, and then the extrinsic eye muscles. So we know that our eyelid really is going to be that piece that closes over your eyeball. But what it really does is it helps to protect your eye from any intense light, any foreign objects, or any impacts. That's why if somebody ever, something's coming at you and you think it might hit you, your first instinct is to close your eyes. That's your body's way of a natural reaction to help you. It's the same way if you have something coming at your eye, your natural reaction is to close it. That's the eyelid's reaction to help protect your eye. The conjunctiva is that mucous membrane that lines the underside of your eyelid and the anterior part of your eyeball. This is really what kind of helps keep your eye moist. Then your lemmacril apparatus is where your tears are produced. This is also where your tears get stored and then subsequently removed as needed. Alright, so it's now time to kind of discuss some of the common disorders. We've talked about the eye, we've talked about its structures. Now let's talk about some of the diseases and disorders that are associated with the eye. The first one that you might hear of quite frequently is called an astigmatism. This is a condition that is caused by the irregularities in the curvature of your cornea and the lens. Generally, patients who have an astigmatism will complain of having blurry vision. They could be having problems seeing, so they'll be squinting, or they might complain of a lot of headaches. Generally, in order to treat an astigmatism, we're going to use glasses or contacts, but you could have a surgery to help reshape that cornea so that problem will be taken care of. Next problem you might hear of is being cross-eyed or wall-eyed. This is generally where one or both eyes are weaker than the other, and maybe they either turn inward or turn outward. Patients with this disorder may have problems with depth perception and maybe complain of having double vision. And generally how we're going to treat this, it could be with glasses or contacts, but other times we have a patient wear a patch over the stronger eye, so that way we force the weaker eye to actually become stronger and be the one that we use. And as a last resort, we could do surgery as well. Now, some of the other ones that you might hear are myopia, hyperopia, and presbyopia. So that's nearsightedness, farsightedness, and farsightedness that is brought on related to age. So myopia is nearsightedness, and that means that you actually have problems seeing far distances. Hyperopia is farsightedness, where you have problems with seeing close up. And the presbyopia is actually that disease that's farsightedness, but directly related to your aging process. All right, so that is chapter 26 for you. We're going to go ahead and move on to chapter 39 now. So chapter 39 is going to discuss the care and the study of the eyes. This branch of medicine is the one that deals with the structure, function, and diseases of the eyes, and that is called ophthalmology. Now, most commonly you hear two terms and two providers when you hear ophthalmology. You hear an ophthalmologist and an obstetrician. So an ophthalmologist is actually the medical doctor who can perform eye exams, they can perform surgery, and they can prescribe the medications, glasses, and contacts. An optometrist is the actual technician who specializes in grinding those lenses down and preparing the glasses or contacts. So try not to get those two confused. An ophthalmologist really is the provider that you would see. There are a number of types of eye exams that we can use to help diagnose and treat certain vision problems. And when you're working in an ophthalmology office or even a primary care office, you're going to have to use some medical abbreviations and medical terms to help with your documentation, especially when you're doing those exams. One of the first acronyms that you might hear is the word PERLA. That's P-E-R-R-L-A. And what that stands for is pupils equal, round, and reacted to light and accommodations. When you're doing an eye exam or a vision exam, you will also be looking at the patient's pupils, so it's important to know the correct acronym to use when charting. When you're performing other tests and vision exams, what you'll be doing is looking at the right eye, the left eye, and then both eyes. So you need to know the abbreviations for that as well. The abbreviation OD stands for right eye, OS stands for left eye, and OU stands for both eyes. Now, as medical assistants, we can be doing these exams for the provider, and any type of exam that we're going to do or test that we will do, what we'll be testing is actually called visual acuity or clarity of vision. Normal vision acuity is actually 20/20. So that's always something to keep in mind. That's the normal. That doesn't mean everyone is at that 20/20 level, but it's still important to know what normal is. As a medical assistant, you will be responsible for assessing visual acuity and looking at things such as distance acuity, near vision acuity, and color vision acuity. So let's take a look at each of those. So distance acuity is actually measured using what we call a Snellen chart. This is a chart that places large symbols, and the largest ones will always be on the top, and then every line below that will be descending or decreasing in size. Your patients who are adults, 5 years or older, will be standing about 20 feet away and will read each line. If they are a child under the age of 5, we actually move them up to 10 feet away. The result your patient receives is the last line that they can read without any squinting or errors. And your result is always read as a fraction. So for example, 2020, 2030, 2040, 2050. And how you read that is you read the first number first. So at 20 feet, you can read what other patients read at 30 feet. Yes, I had to think about that. Next one we'll be dealing with is near vision acuity. And this is done when patients complain of having problems reading or performing tasks up close. We'll be testing using what we call a Jaeger chart. And really what that is it's a card that has several different paragraphs on it. And what we'll have the patient do is they will hold that about 14 to 16 inches away, or normal reading distance away, and they'll begin reading those paragraphs. Just like with the Snellen chart, the largest paragraphs are on top, and then they decrease in size. We want to know what the last paragraph is that the patient can read easily without having any squinting or mistakes. And then that will determine the patient's result and help us maybe to determine farsightedness. And the last one we're going to look at is color vision acuity. This will test your patient's inability to distinctly differentiate between colors of a spectrum. It's important to know that patients with color vision problems can be born with them. They can be inherited or acquired throughout a disease or an injury. More commonly, you're going to see males have color problems or color vision blindness or color blindness, and that just happens to be a hereditary thing that has happened along the way. The color vision test will use a system called the Ishihara test. What this is it's a printed card or book with a single circle, and then we have little dots on the inside. Those dots will be two different colors, and the dots will either have an illustration containing a number or curved lines or shapes. The patient must correctly identify 10 out of 14 to be considered having normal color vision. Along with doing the visual acuity testing, medical assistants may also be responsible for performing irrigations of the eye and ear. So this is where you will rinse the patient's eye out from either foreign objects, foreign substances, or chemicals. So that's the irrigating of the eye. And this is really going to be using what we call a sterile technique. You want to use sterile gloves and you want to use sterile water. You'll have the patient either sit or lie down. I think that lying down makes it a little bit easier because then your patients can just roll to what side is affected. And then they'll actually place a towel under their face and then a basin cup underneath the eyes to catch whatever will come out of it, along with the sterile water that gets pushed through. As the medical assistant, you're actually going to open the patient's eye with your non-dominant hand and spread the eye with the index and thumb. And then you will take a syringe full of sterile water and push it into the eye at the other side, so the top of the eye, so anything that is in the eye will flow out of the eye. You'll do this until all of the solution is used or the object has been removed. And eye irrigations or eye installations of medication is where you're actually going to apply medication to a patient's eye. This is something that medical assistants either may perform in the office, or you might be instructing the patients how to apply the eye drops themselves at home. The procedure will be set up very similar to that of the eye irrigation, but generally this one is easier if the patient is sitting and they tilt their head back. I generally have my patients, once they tilt their head back, look up, because if they see the drop coming, they'll actually close their eye down. The medical assistant will then pull the eyelid at the bottom down and hold the dropper about a half of an inch above the eye and apply the recommended amount of drops as prescribed by the provider. Make sure that your patient has a tissue in hand so that way they can dab their eye or their cheek if the eye drop does run Alright guys, so that is the brief overview I have for chapters 26 and 39. This week, I really encourage you to make sure that you're reading your chapters, so you're not only prepared for my class and doing your discussion posts, but you're prepared for your lab class that will be on the same topics this week. This week you only have your one discussion post, and that's going to be around the topic of 20/20 vision. What you will need to do is do some research and discuss if 20/20 is the best vision possible. You also need to discuss if it's bad if a patient doesn't have 20/20 vision, and if it's a good thing, why? Tell me why. Please make sure that your initial discussion post is completed Tuesday by midnight and that your 2 responses to your classmates are completed Saturday by midnight. Any questions that you guys have, please feel free to reach out to me. I can help in either modality, the online lecture or the lab class. And I look forward to having a wonderful week with you guys. Bye now.